Good morning, Danielle. Hope you're doing well.
I am.
Um,
Thank you. You as well.
Good. So, as you know, there's a whole variety of topics I would like to touch on, and I just came up with this. The use of antidepressants and depression, due to the fact the idea is prompted by the amount of patients I've had lately that are dealing with this type of condition. So, I thought it would be appropriate to bring this up as a subject. So,
Absolutely.
so basically, the idea of what we define as depression in a society model is
hmm
variable. And I think many of us know this. As an example, what one person may consider depression, another person may consider as just sadness or an emotional fluctuation
Mm.
that humans or mammals in a wide arena are basically evolved to feel. The
hmm
idea of feeling sadness is not depression. And that's the first thing that I wanted to bring up, is that oftentimes there's a misunderstanding of sadness and depression.
Mm.
And the primary subject here is, if someone is undergoing sadness or grief, uh, are many people quick to jump the gun and say they're suffering from depression?
Mm-hmm.
And that's really important. That's an important topic to touch on. I think it's important to evaluate what depression is, because there's so many definitions of depressions. You can
hmm
go through gradient, from
hmm
1 to 100 on what one person may consider depression, one person may consider anxiety, one person may consider as something else,
hmm
just primary grief. Um, the primary concern I have here is an evaluation that's premature on suggesting that someone who's just going through sadness or grief immediately is treated as depression, and consequently given primary drugs, selected drugs. As an example, SSRIs, which is selective serotonin reuptake inhibitors.
hmm
And that's the more recent medication that's being used. It used to be MAOs, which have a different type of directive. But the question I present to many people is, are we being premature in understanding or defining depression?
hmm
And number two, are we being premature in electing to give these types of drugs, SSRIs as an example, in the use of something, or for the use of something that may not be definitively depression, if that makes sense?
It
We,
does. And I think I would just jump in and say that, these drugs aren't without side effects. And so you're quick to throw something that may cause a whole range of problems, and you're not even tackling the original problem in the first place.
Exactly. So to give you an idea, the role or the consequence or definition of depression has risen.
hmm
I believe it's from 2017, I can't really recall, to current, is going as increased as much as 63% or higher.
hmm
Think
hmm
of that.
Right.
In that
Right.
span, the idea of depression has risen that significant, to a point of where now in the US, it's, I believe, over 10% of
Right.
society. I think it could be even close to 20%. I
Right.
believe it could be 17% of the population has been diagnosed with some form of depression. And this may envelop anxiety as well. But
hmm
the point I'm trying to make here is, why the rapid increase, as we have talked about before in other conditions from our previous podcasts, like diabetes and other things. Why are we seeing this increase in what is being defined as depression?
hmm
And it's substantial, to where if it keeps growing at the rate in which it is now, that we should hit a platform of nearly, if it goes on for another 7 or 8 years like this, there could be over 40% of Americans classified and being treated for depression or anxiety.
Right. So I have two questions on that. One is, do you think that the definition of depression, as guided by the American Medical Association, or the way that the insurance companies code illnesses and things like that, do you think that that definition has broadened, and so they're including more people in that label of depression, when again it's not in fact depression, it's something other, like you touched on, like anxiety or some other condition, but they get lumped into this depression category?
I
So there's
do
that.
agree. I do agree with you. I believe that's a key
Partly
point.
what's happening, but then also, doesn't it feel like it's such a funny, like, if more and more people are being diagnosed with any kind of depression or anxiety, or isn't it seems like it would make sense to not just, again, slap a drug on this, but really kind of figure out what the cause might be for this kind of widespread, issue that's happening. Because something is clearly wrong in our society that this is jumping like this.
Exactly, and it's not just our society. It's
Right.
Europe,
Oh, everywhere.
Scandinavian countries,
Absolutely.
exactly.
Yeah.
And are we looking at society, the increased population? There's so many variables that we could look at. The key to me here is how we go about addressing the condition, regardless if it's diagnosed correctly or incorrectly.
Yeah.
Is it important, or is it imperative to start giving a drug that has so many side effects that post SSRI side effect or emotional blunting? Emotional blunting is where people don't feel anything anymore. It's like, well, my house burned down. There's no impactful sadness, and yet if they're given a new car, there's no impactful happiness. It's just literally, and the increase in visual dysfunction. We're seeing glaucoma. It's basically a narrow angle. It's called narrow angle glaucoma phase that is increasing. We're seeing an increase in cardiovascular problems. We're seeing even something called serotonin syndrome. And serotonin syndrome is basically what happens is a mild range of feeling more of the symptoms that it's meant to treat, to deadly. And we see this by taking things like SSRIs. And it's interesting to note that in studies with SSRIs, the favorable response that was given were generally, I can't remember, I think it's like over 70% of the favorable responses to SSRIs reported to the FDA were linked to pharmaceutical companies. So it was heavily weighted to
it was,
favor.
of course, to favor
And
them.
people can look this up. It's right there. It's noted that many people were linked to the pharmaceuticals.
Right.
And this is obvious. I mean, you can just look this type of thing up. Plus, in addition to that, the other studies that were given were so varied that it is difficult to define if we're seeing something that's beneficial or not beneficial. My concern is long-term effects by using SSRIs. What do we have? And our viewers, any of them, can look at the side effects. I encourage that. It goes on. And is this worth the idea of maintaining a life form that would be considered consistent with what we consider content?
Right.
And that's my concern, because I think what's happened, my personal viewpoint, is we've arrived at this dialogue that we think that everything should be rosy all the time. We've painted this picture that we should never feel sadness, that we should never feel grief, when indeed
No.
these are emotions that are instilled deeply within the human format and other
Right.
mammals as well.
Right.
I mean,
Right.
it's a wonderful thing to feel grief and sadness when we can feel the opposing, which would be joy, happiness, or whatever.
Right.
And I think what's happened is there's been several bounds that have been overstepped, meaning that if you're feeling sadness, you shouldn't feel sadness. And
Mm-hmm.
therefore, as society, the world society, we have
Mm-hmm.
the right as humans not to feel sadness or grief. And it
Mm-hmm.
indeed, painting this picture puts us in a scenario that could be very detrimental to our health because of these side effects from these SSRIs or MAO. MAOs really aren't used that much anymore, but
Mm.
that's my concern is what's
Yeah.
happening
Right. Right.
as a long-term effect by doing this, by using these procedures, and yet the idea of what we're treating, is that even correct? Is that something, are
Is
we
it
trying
something to
to,
treat? Right.
yeah, are we
Yeah.
are we moving out of the box of understanding that humans have the ability to feel all basic five emotions: grief, sadness, joy, worry, anger,
Mm-hmm.
that type of thing.
Right.
So
And it's
it's
yeah.
not, SSRIs are now being prescribed for people with over anger issues.
Mm.
So how far are we going to increase the envelope here? Okay, if you have anger issues, we're going to give you an SSRI. Okay,
Mm-hmm.
you have grief, we're going to give you an SSRI. You have sadness, we're going to give you an SSRI. We are
Right.
now trying,
We're
or
gonna.
you have worry. We've now removed, or we've now addressed four of the primary five basic
Right.
emotions
Right.
by using a medication without saying, hey, it's okay to feel this
Right.
if you
And figure
move
out
through it.
and move through
Mm-hmm.
it exactly, and figure out how to cope with it and how to process it and move it on.
Exactly.
Because I would argue, and I think you probably see this in your practice as well, that the SSRI, a drug will mask it, but I think the physical symptoms will still manifest themselves of someone who is suffering from anger, is suffering from anxiety, any of these things. They wonder why they're having health issues. Health issues are caused by suppressed emotions.
Mm-hmm.
And just because you can't feel them doesn't mean your body is not still
Mm-hmm.
feeling them.
Mm-hmm.
You're just not expressing them.
Exactly. Now, what's interesting, some other uh, anecdotal scenarios,
Yeah.
is that religious people, according to certain statistics, people that are
Mm-hmm.
theists, not necessarily monotheists, but theists, basically have a higher rate of depression and a higher
Mm.
rate of suicide.
Mm.
So that's interesting to think about, meaning that,
Mm-hmm.
and the reason I bring that up is the fact that are humans now looking for um, validation from external sources. And I don't mean this just in religion. I mean this in daily life. Like, I wasn't validated for what I did at the job today. I wasn't validated for,
Right.
how I
Right.
look. I wasn't
Right.
validated for how much money I make. And are
Right.
we interweaving this need for external validation to define who we are
Mm-hmm.
principally, and our confidence and the role of understanding that we're okay the way we are as humans?
Right. Right.
And that's my social concern, is what is
Absolutely.
happening when we continually seek external validation.
Well, and you know what just makes that so much worse is social media, interaction
Mhm.
online, where
Exactly.
you get sucked into this external validation thing, and it becomes, I think, addictive in some ways.
Mhm.
Whether it replaces human contact, which is far more valuable than
Exactly.
something.
And
Yeah.
another number which is I find interesting is, according to statistics, the use of SSRIs is higher in females than it is males.
Mm.
Now, I'm I'm not saying this is the case, but I'm suggesting something to maybe consider. That, do females have feel like they have a higher obligation to fulfill a particular role in society, as far as how they look, as
Mm-hmm.
far as how they're accepted?
Mm-hmm.
We all understand many societies value women, unfortunately, in my opinion, on just their physical looks.
Mm-hmm.
And it's unfortunate.
Yeah.
And the way they're accepted, as far as, how tall they are, how beautiful they are, or whatever.
Right.
And consequently, is this in the same format of external validation? If I'm
Right.
not validated for what I appear like,
Right. Right.
I'm not going to be accepted in
Yeah.
life.
Yeah.
And I'm
No,
not suggesting this is always the case. I'm suggesting, is this a possibility that this is
absolutely.
the case?
And again, you go to the internet and you see how this is starting to occur younger and younger in younger people,
Exactly.
where they
And
are just bombarded with all of this information that says they're not pretty enough, they're not good enough, they're not living this magical life, because look at this online, which is all fake anyway. And it's this horrible cycle. I mean, it just is,
exactly.
yeah,
And the suicide rate, consequently, with the use of
I know,
antidepressants in young people is
I
increasing.
know. It is, it
So it
is.
really, my my point that I'm trying to make here is that if an individual feels that they're in an emotional rut that they can't get out of, they can't function,
Mm-hmm.
there are options
Yeah.
rather than like an SSRI
Mm-hmm.
that can be used quite efficiently to
Mm.
get to get these individuals out of a rut
Mm-hmm.
where they're able to function accordingly, and the side effects are minimal. And that is my concern. Once again, my analogy: do you use a sledgehammer or a chainsaw? Let's use this. Do we use a chainsaw to cut a cube of butter, a stick of butter?
Right.
We don't
Right.
need to.
No.
And what we're
No.
seeing are these side effects from
Mm-hmm.
SSRIs.
Mm-hmm.
Currently, we haven't
Mm-hmm.
even seen the side effects that are arising now that are probable. I
Right.
mean, I, it just the risk of suicide, the serotonin, serotonin syndrome I
Mm-hmm.
mentioned.
Mm-hmm.
Now they're talking about basically situations to where people are beginning uh, to see doses where their bone material changes, where you
Mm.
have an increase in fractures, you
Wow.
have an increase in bleeding,
Uh-huh.
cardiovascular problems, even though it looks like at this point that it doesn't appear to really influence the coronary heart
Yeah.
conditions or coronary heart disease, but vision, emotional
Right.
blunting, all
Right.
of these things. I could just keep going. Post SSRI situations, sexual dysfunction, all of this. And
Right.
then consequently, what happens is that can cascade if an individual feels sexually inadequate and they're dysfunctional, then their relationship, it can
Mm-hmm.
consequently impact the relationship. The,
Mm-hmm.
the question I have, is it worth doing this for what could be misdiagnosed?
Right.
It's just
Right.
simply a process of life, and
Right. Right.
that's my concern here.
Right. So what are some things that you know that that people could try if maybe they're considering an SSRI and they're seeing this and saying, well, maybe I don't want to go down that road. You
The
know,
first
what
thing
do
I
you
would
recommend?
the
Yeah.
first thing I would suggest is something called 5-hydroxytryptophan, and 5-hydroxytryptophan is basically, we've all heard of tryptophan,
Mm-hmm.
an amino acid
Yep.
that produce or synthesizes eventually serotonin.
Mm.
Now, serotonin is a neurotransmitter; it's not a hormone. Uh, Melatonin is a hormone. So the
Okay.
first thing I would suggest is in individuals can start very minimally at 50 milligrams or even 25 milligrams of 5-HTP per day. See if they see any difference with that.
And how
It,
long? Like for 2 weeks?
oh
Less than
no,
two
you'll
weeks?
see it. You should see a difference within about 3 to 4 days.
3 to 4 days. Okay.
Pretty rapid.
Okay.
The other thing, if anxiety is present, then they may want to try something. Well, Meehan Formulations has something called Body Comfort, and the
Mm-hmm.
Body Comfort is intended to increase neurotransmitters like dopamine, as an example,
Right.
and that has been shown to be very effective for
And
calming down anxiety.
right. And body comfort is a combination of things, right? It's a combination of
Correct.
kava and
Uh-huh.
GABA, and there's one more. What's the other thing in it?
Mm-hmm.
I'm trying to. Oh, look, I have it right here. Let's see. Oh, B6 for one
Yep.
thing, glutamine for another, and then you're going to have to pronounce this one for me, the phenylalanine?
D-L-phenylalanine or L-phenylalanine, yes.
L-phenylalanine. Oh, that's a fun one. Okay. But yeah, so all of those kind of work together to
exactly
to help
to synthesize
right.
a neurotransmitter.
Right. So it says on the bottle you should take 2. Let's see, what's it say? 2 twice a day.
Some people have taken it and they only need 1 actually.
Okay, so you could start with 1 twice a day and see how that works.
And
then you could go to 2. And if 2's not doing anything, could you go up from there?
Sure, you can.
Okay.
Yeah, without any real negative side effects.
So you could go to 4 twice a day.
If someone is currently on antidepressants, like an SSRI with any of the things I suggested, you should be cautious and stop taking the antidepressant, or vice versa. You don't want to take them together.
Don't take both. Okay.
No.
And then, but stopping the SSRI, is that something you should taper off of, in your opinion, or you can just stop?
Yeah, no, you can generally stop or taper off is preferable. Yeah. So you don't hit a post-SSRI syndrome.
Right. So taper, yeah.
Yeah, our concern is.
Yeah.
But once again, it's important before starting, in my opinion, an SSRI or antidepressants, is to evaluate and ask ourselves, are we just experiencing sadness or grief if you've lost a spouse or a close one, or and to feel that and to experience that, and it's okay to feel sadness and grief.
Right. No, it's absolutely true. I mean, you can't. That's called life. Stuff happens.
And as you know, with meditation and everything else, a lot of people, I think meditation's great, but if you're doing it to escape a situation, a lot of people use that. Yeah. Which I'm not saying it's bad, but understand if you're using something like this to escape, then meditation may be not favorable. It's almost like, I don't want to face life. I want to just meditate because that's my way. And then you get back to life and it's really not doing anything. Right. It's definitely healthier than an antidepressant. That's for sure.
Absolutely. Absolutely. But it's a tool. It's not.
It's just like,
you gotta,
me personally, and this might offend many people in religion. Are we looking for external validation? Are we looking for something else rather than looking inside of ourselves and say, I'm okay the way I am? Right. And, when I know very many people that leave church on Sunday or whatever day it is, and then on Monday they're feeling bad again because they're not in church. In other words, they become dependent on an environment that it's like an escape mode rather than a mode of, you know what, it's okay, I honor this. And I'm not criticizing religion. I'm not. That's not what.
No, that's not criticism. No, that's not.
I'm just saying why have we seen a vast majority of people who are religious on antidepressants? Is there something missing? Right. Is there something missing in people that they want more, or they're searching for more and they're not able to achieve that? And that's my point. Same with meditation. Yeah. So I'm kind of hitting both areas. I'm hitting Eastern philosophy and Western philosophy. So
right. I know. Well, and we can't even. I think we have to touch on 2 main areas that I think can contribute to the way people feel their emotions, and that's going to be activity level. Exercise is a great reliever of stress, and if people aren't active enough, it can make a difference. And the other is food quality. Exactly. Eating crappy food can make you feel like crap. Exactly. And so then taking a drug to try to overcome that, if you maybe change your diet, you might actually feel better, and you're not going to be on a drug for the rest of your life.
Exactly. I mean, and isn't it
sugar is,
Isn't it interesting that the crux of most of these podcasts revolve around diet, revolve around food, what we put in our system.
That thread is there 100%.
I mean, we see this correlation on a continual basis.
Absolutely.
And then obviously, to say, as I've mentioned before, most people understand that they're not eating good food. They do it anyway. I know. It's deliberate.
No, it's a crutch, or it's a, I don't even know what it is, but they do it anyway. They
And then they
know
feel,
better.
and then they feel bad after they do it, and then it
Mm-hmm.
just, this cascade occurs to where it just
Right.
continues.
Right.
You fall into this almost like a black hole,
Mm-hmm.
and then you
Mm-hmm.
start relying on prescription drugs, you being plurality.
Yeah, of course.
People generally rely on drugs, and then the drugs consequently make things worse over the long period.
Mm-hmm. I know.
So
I know.
that's the point I want to make, and that's why I
Yeah.
wanted to talk about depression. Is a few points to touch on here.
Yep.
Number one, are you really suffering depression, or are you just going through a natural phase of grief or
Mm-hmm.
sadness?
Mm-hmm.
It's okay to feel an extended length of sadness. That's okay. Many of us have. Number one. Number two, are the directives used generally to treat what could be often misdiagnosed as depression safe for you?
Right.
We can almost evaluate they are not the safest things in the world. They're
Right.
not.
So
Just,
for people, just let's touch on that real quick. So SSRIs, can you give me an example of one? What would be an SSRI, a brand name?
an SSRI would be something like, oh man, you could have the old ones, the MRIs, or the not the MRIs, but the old MAOs were like, you've heard of things like Prozac. Do you remember hearing about Prozac and things like that?
Yep.
SSRIs could be, this.
I'm gonna look it up here. Let's see.
Yeah, well, there's so many ones I can give the scientific name, but
I know.
so many different ones are, Celexa
Right.
is one that I can think of. What else is
I'm looking. Let's see. What do we got here?
Lexapro?
Okay, there you go.
Yeah, things like, those types of things. People can look these up. There's so many.
Yeah, I know. Sometimes if someone they just don't, so like fluvoxamine.
Well, yeah, or like Zoloft.
Okay.
Let me think if I can think of another one.
Celexa, Lexapro, Prozac, Serafem, Symbiox, Paxil. Yep, Paxil, Zoloft. Yep. So those are some common ones. I see. Okay.
Mm-hmm.
Okay.
And the ones that I see more of are Celexa in the clinic. Lexapro is another one that's more commonly used.
Yeah.
There are probably some others that I'm missing. I'm just going off the top of my head. Some other.
Yeah. No. So I looked those up. So that gives the people some idea of what we're talking about.
Right.
Yeah. We did.
So those are the basically the SSRIs that need to be considered, and we have to look at what the side effects are. That's my concern.
I know.
What are we doing with side effects? What are we, do we have to start treating the side effects?
Right. And what are you doing long term to your brain chemicals? Nobody wants to be on these for a long time.
Well, but that's the thing. Many people feel they want to be. Does that make sense?
Mm-hmm.
Many people want to feel they want to be on it because they feel that's the way they should feel, where you have this emotional dysfunction to where it's just a blunting, as I mentioned before. And that's something to keep in mind.
That people think this flat line of emotion is normal. Like that's what it should be versus having the ups and downs in life.
Exactly. And we just have to look at, is this normal to feel sadness? Is this normal? And it is normal. That's basically us as mammals, if that makes sense.
Yeah, so, it does.
Anytime an antidepressant like an SSRI used, nerve cells, you have nerve cells, and messages are translated through those nerve cells and via a chemical synapse. And that synapses, basically a synaptic cell, sends the information to neurotransmitters, including serotonin, blah, 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 all this stuff. So what happens is the reorganization of an inhibitor, such as serotonin uptake inhibitor, means that serotonin is meant to stay on the synaptic gap or cleft for a longer period of time. Does that make sense?
It does.
But what happens over the long term is the concern, because what you're doing is you're altering, or what we're doing is altering the way serotonin serves as a primary neurotransmitter. And that's my concern, because what happens is the serotonin level drops within my synapse, and as it does so, you can have what is referred to as a downregulation. And a downregulation is what people want to try to avoid. And by doing that, what are the effects that we see? You know, the effects as you continue to increase the uptake in inhibition or inhibitor response of serotonin. This is the concern.
Right.
And by the way, SSRIs are being used in some cases for migraine headaches. Yeah, literally. So what
do you
happens?
suggest, not to go off on a tangent, but what do you suggest for migraines? Because that's a big problem for people.
Migraines is basically aggregation of the platelets primarily, fluctuations of hormones. We touched on this with the drop or change of estrogen and progesterone.
Right.
And you have various things that can be addressed in other ways safely rather than using an SSRI.
Right. Oh,
for
sure.
By continual use of SSRIs, you have, what happens to the ability of expressing neuroprotective actions within the neuro, what's happening within our brains.
Right.
If we're looking at that, and that's my concern, is what happens
it's scary.
over long-term use of the nerve cell and the chemical synapse, and I could go on, and that's my concern.
Right. And I think it's something that modern medical doctors don't really want to address, or even think it's a concern, or don't know enough to be concerned.
Exactly. It's probably the latter, of
because
just not being informed.
They don't have the biochemical background to look at these things and see what they're actually doing long term.
Right, exactly.
Yeah.
So for our viewers, I just encourage entertaining, number one, if you are depressed, or are you just experiencing the typical emotions that humans feel at times, sadness and grief.
Right.
Number two, if you do feel you're going through a long-term depression that you can't get out of, then what is the best way to manage that? There are other factors that can be very efficient rather than jumping into prescription SSRI.
Right. For sure. Well, this has been informative, and I hope people want to comment and ask questions below. We're open to all comments. And if you have any questions, you can email us at support@Meehan Formulations, or you can leave a comment below. I think we're just about out of time today. It's time for another patient for you. But thank you for this topic. And I hope it sheds some light on this for people. And get in touch if you want to talk about it.
Okay. Thank you for your time, Danielle.
Absolutely, Kevin. Have a good day.
You too. Bye-bye.
Bye-bye.